you come along and bingo.
We're going to take two cuts, a bivalve cuts. We're going to go on this side of the arm and on this side of the arm, trying to avoid the bony areas in the arm, mainly the wrist. So we'll use the fat, fleshy part of the arm to kind of absorb the shock of the blade. Never want to run the blade over something bony like the finger here or the radial styloid or the ulnar styloid. For that reason, we're going to go on the dorsal side and the volar side straight down. Now the correct technique is to take the saw and push down and lift up, move over, in and out, in and out, in and out, in and out. This will reduce the amount of heat the blade produces, eliminating the burn on her skin. We're going to start here and go down towards the knuckles. Alright, that's one side. Getting harder?
Yeah.
Alright. So indeed, that blade is really hot. Even though I gave it an exaggerated amount of time of cooling, you saw as I lifted the blade out, I paused for 1 second and dropped it back in. A little bit of an exaggerated technique, but I slowed it down so you could see the proper procedure of removing the cast. In and out, in and out, in and out. We've been having some problems with the emergency room putting on long arm casts and bivalving them, just like I saw. Generally, the patients are under conscious sedation, so they don't know what's happening. They're not able to tell the doctor that their arm's burning. 3 weeks later, when they come into our department, we'll take that long arm cast off completely and we'll see burn marks on their arm. Healed, but still burn marks. Now I can really open it up and get as much room as I want. Slide my scissors through the material. So I don't get the saw. Okay, now it should slide off nice and easy. And there it is. Short arm cast, two cuts, also known as bivalve.
For many children, removing a cast can be a traumatic experience, sometimes even leading to anxiety attacks. This can present a major problem for children diagnosed with cardiomyopathy. There is a quieter, more friendly-looking cast saw currently on the market. There are some limitations to it, however. Plaster casts cannot be cut with this device. Its use is limited to fiberglass. The design of the cast saw makes it difficult to maneuver around joints and is optimal only for short arm casts.
My name is Michael Ginsberg. I'm an orthotist here at JC Davis. I've been here for 6 years. I started as a volunteer and worked my way up. Something that I very much enjoy doing. And basically in orthotics we make braces for all body parts other than teeth. Basically what we do is we start with the patient and a prescription that calls for us to solve a particular deficit of function in the patient, whether it be weakness, contracture, some sort of a burn situation, it could be traumatic or degenerative. We are then tasked with designing a brace that will address the patient's needs, take an appropriate mold and measurements to make the brace, make the device, and then provide it to the patient. One area that we have a real challenge to this day is hip flexion assist devices. Our hip flexors are very important to determine how we're going to walk. It's what allows us to kind of get a nice long step and advance our weight, our leg forward. So when the hip flexors are weak, those individuals are not going to be able to take a very long step. Sometimes they will have a little shuffle gait where it's very small steps being taken, and it costs a lot of energy to walk in that pattern. A lot of those individuals simply cannot walk at all. Currently, that's an area where there's not a lot of products, and the products that are out there have not gone through sufficient peer review to where they have been rated as an effective medical device.
Michael shows us an example of a hip flexion assist device. It is made up of a Velcro waistband, tension bands, and foot attachment. The elasticity of the bands propel the leg forward for each step. Michael explained several issues with the design.
The downside to this brace is, in addition to being a flexion assist, it kind of pulls you off into abduction. It's a brace that has to be worn over the outer clothing, has some bulk associated with it, and is very visible. Patients like to hide their braces. Patients don't want to advertise that they have a limitation. So relatively bulky componentry that is very, very obvious has poor compliance. And even if the brace is 100% effective, but it's in the closet, it doesn't accomplish anything for the patient. A very major class of devices that is that has come around quite a bit is a stance-controlled knee, ankle, foot orthoses, KAFOs. The idea of those devices is they have the knee locked in full extension, or patient's maximum full extension, when the weight is on the leg. But when the patient is clearing the leg, the patient is in the swing phase, the knee joint is unlocked. So it permits the patient to bend the knee, advance the weight forward using their hip flexors, straighten the knee, it locks, you place the heel, you can stand up on the leg, and the knee won't buckle. That is an area that is getting a lot of research and a lot of funding and a lot of interest, because having to walk at all times with your knee locked out requires a very strong adaptation, and it costs a lot of energy, especially if you have somebody who's bilaterally involved. If you have a spinal cord injury patient where they have no knee extensors, they have both of their legs locked out at all times, they have to circumduct at the hip to advance their weight forward. And that's a very energy expensive pattern to walk in. But there's still a lot of patients that would be much benefited by it. They can't get into it, either because they have a contracture at the joint, maybe their hip flexors are weak, so they can't advance their weight forward, and we don't have a good hip flexion assist to assist in that, or it is prohibitive in terms of price. A very interesting type of a brace that I'd like to talk about, and they're not very commonly done at this point, is called an RGO, reciprocating gait orthosis. They were very popular mid-80s to early 90s. And they are designed for an individual that has no strength, essentially from the waist down. The joint that is attached to it couples the motion of the trunk to the motion of the hip. It has your knee full-time locked, your ankle full-time locked, and as the patient leans back into the side, it advances the leg. Patient leans forward, the leg gets planted, lean back into the side, the opposite side is advanced. It sounds too good to be true. You have somebody that has no strength, and they can stand and walk. And it's both true and too good to be true. It works, but it's very heavy, and it's very energy expensive to walk in that pattern, because we have to use our trunk. We have to move our center of gravity with every footstep, or actually twice per gait cycle, once for each leg. There was a study that was published in the late 80s that determined that it is more energy effective to get from point A to point B in a wheelchair than to get from point A to point B in an RGO. And as a result, RGOs have largely vanished. They are very, very technically difficult braces to make. You have to align many joints in a plane. It crosses a very large surface area of the body. They have a lot of weight, a lot of bulk, a lot of moving parts, and they are very expensive.
These devices may become more favorable due to the evolution of stance control knee joints. Given that the knee can now bend with stance control technology, the energy cost of walking in an RGO will decrease. As a result, patients can assume a life of greater independence without a wheelchair.
Another emerging technology that I would like to talk about is functional electrical stimulation, which is usually abbreviated to FES. It is a very promising technology that is essentially in its first or second generation. The line of thought goes, you have a small electrode that gets attached to an area where the nerve that innervates the muscle is close to the outside of the body. And primarily they're done as a toe pickup devices for dorsiflexion assist devices. They get attached on the outside of the knee to innervate our peroneal nerve. The current devices are programmable, so we can teach them when to fire off to allow the muscle to contract, given that the nerve is now stimulated. It's a technology that still has yet to fully mature. There are some patients every now and then that are followed by expert practitioners, and on paper seem like they would be a perfect candidate for it. But you watch them walk, they're still dragging their toe, they're still hyperextending their knee, and it's still a technology that needs to develop further. The promise of it is magnificent. You have much less weight to carry. You're actually using muscle power rather than external support that a patient has to carry. We would love for them to have more different joints that we can intervene on with those types of braces. Maybe elbow motion, maybe knee motion. And there's a lot of room to grow from the base that is currently established.
Face masks provide total contact to prevent scars from hypertrophying. They are very challenging devices to make because of the fine contours unique to each face. If a gap or artifact remains in the mask after casting, it is not only obvious, but also rather tricky to compensate for. The mask is constructive of a very thin and low-temperature plastic that tends to collapse when heat is applied. Making a change to a small area will affect the plastic immediately surrounding. Michael elaborates on complications for patients.
Face masks have an additional stigma associated with them in that you can't hide them. It's very obvious when you have a face mask on. They retain a lot of heat, they retain a lot of moisture. They're tough braces to live with, but they do what they promise. There is an extra bit of difficulty with those devices in terms of we market them as something that will keep the scars from hypertrophy. So to a patient that means they will have less scars, or less noticeable scars. But when you're dealing with a large area burn, you will usually leave some sort of scarring. And to most individuals, any amount is too much. So even if the face mask has been very effective, and from our point of view, those scars look awesome and way better than as if nothing was done, from a patient's point of view, it's not always worth the effort.
I do sports medicine, so I do a lot of sports surgery. I do a lot of ACLs, I do a lot of meniscus tears, I do a lot of rotator cuff tears. Those are more commonly, shoulder and knee are the most commonly injured joints in sports, sometimes the ankle. Tendon ruptures about the knee, like patellar tendon ruptures, quadriceps tendons. So the particular problem that we see with doing an ACL reconstruction, for instance, is this is the knee opened up without the kneecap. Obviously we're looking at the end of the femur and the tibia, and we can turn it sideways as well. So the other ligaments, the collateral ligaments are on the side. The other ligament you see deep in the back of the knee is the posterior cruciate ligament. So the ACL has a very broad attachment to the front anterior aspect of the tibia. So it's in this non-articular area called the eminence. And it's almost 2 centimeters in length, the entire length of the ACL, and it's probably, maybe 10 millimeters wide. And then the femoral attachment for the ACL is, so this is medial and this is lateral. So the femoral attachment is very far in the back of the notch. So it's if we turn the knee over and we look at the condyles from the side, it actually attaches back in this region on the lateral condyle. And again, it's a very wide attachment, sort of an ovoid type of attachment. The ACL has been characterized in having a couple of bundles, the anteromedial bundles and the posterolateral bundles, and they have reciprocal function. One tightens with the knee in flexion, one tightens when the knee is in extension. But in any event, so we're trying to recreate this very complex structure. It actually is a helical design, the ACL, and we're using a straight ligament to reconstruct that. So obviously having guides that can reproduce, where you want the drill. So you can have an instrument like this that will put in the knee from the front. So this instrument would come in, and you can see it has a point that would attach, and the surgeon can move this point wherever. All right, and then the way this apparatus works is it's going to be hard for me to hold everything at once. But so if we put this in here, this is a sleeve that will come down and engage the outer part of the bone. And then let's say there's a drill that we can put this down, and this will actually deploy inside the joint. Now, that's all great, and these instruments work well, and they're all engineered well. But here's the problem. This allows the surgeon, this is dependent on the surgeon placing the instruments correctly to recreate the ACL. So you've got to get isometry. So you would theoretically like to have very little, strain developing in the ligament while it moves from full extension to flexion. And you want to reproduce the normal anatomic course so that it controls primarily rotation and intertranslation, which is what the ACL's job is. That's how you pivot. So it prevents the knee from doing this. So it has to control internal rotation, and it has to control anterior subluxation or translation of the tibia. So you could envision maybe an instrument that is can digitize in the joint. So when the surgeon places this in the joint, you can digitize the footprint of the ACL, let's say on this side, on the tibial side, and then you have another guide, let's say, that will digitize the femoral attachment, and you could have a computer then pick out which 2 points would put the least strain on the ligament that you're putting in. So what would be the ideal point of reconstruction? I mean, I'm just thinking ahead. I mean, nobody has that right now, but that certainly could be a real feasible study. Even I, having done lots of surgery, I don't know exactly on every knee where the 2 precise points are that should be the center of that graft, because you're putting in a 10 millimeter graft, so it's diameter of this drill bit. And if it's off a few millimeters, that might make the difference between success and failure down the line. So I think something like that would be very feasible. Could you improve on current design? So this is a standard drill bit we use, and it's called an acorn reamer for obvious reasons. And one thing about this is when this is in the knee, if you're working to drill, and sometimes we drill from the front of the knee inside out. So let's say we're drilling the femoral tunnel this way. I can't see, even with my arthroscope coming in from front, I can't see exactly what point that engages. In other words, so when I turn this over, is this drill bit off? Am I going to drill a tunnel that's going to break through the back cortex here or not? So could you make a translucent drill? Is there a material that could be translucent that you could see through and visualize the footprint before you actually start your tunnel? So that's another idea, something like that. Other people there are a few available, but flexible drills to try and drill at an angle. So that, obviously this is a relatively rigid structure, and I'm forcing this, my tunnel is forced this way by the femur here, by the bony, I'm constrained by the bony landmarks, right? So I'm constrained to drill this way. But how about if I had a drill that I could make it go at like a 90-degree angle or 45-degree angle by a particular type of guide that I could put in and would have it curved? That's something else that might be advantageous. So that's just for ACL surgery. We actually, I just was over, when I went to get this bone from the orthopedic clinic, one of the nurses grabbed me and said, there's a patient with a quadriceps tendon rupture who needs surgery. So there's a case where there's not a great system out there necessarily. We still rely on sutures placed through drill holes in a bone. to pull the tendon into the bone. There's got to be a better way to fix it. You know, there has to be some better way to get the tendon to the bone.